So we were talking about smooth muscles. Smooth muscles. So there are only three muscles in our body: skeletal muscle or striated muscle, cardiac muscle, and the smooth muscle. So this is the last type of muscles we need to know in our body. So it is quite exciting. And if we do not study smooth muscle properly, I think we will be discriminating the smooth muscles, which is not a good thing. And at the same time, these smooth muscles, they are present in many different parts of our body. So it is something, some way we cannot see. So those muscles in along the gastrointestinal tract. So let's say from like esophagus, stomach, duodenum, jejunum, ileum, colon, rectum. So these muscles are made of smooth muscles. And we know that cardiac muscle is only present in our heart, nowhere else. And the skeletal muscles, they are the muscles, voluntary muscles, and they are attached to the skeletons. So number one, smooth muscles are present in the gastrointestinal tract. Number two, in urinary tract, which is somewhere we cannot see. Respiratory tract, very inside, reproductive system, and our blood vessels and eyes. Yeah. So the question is, where do we see smooth muscles? These are the sites where the muscles are made of smooth muscles. And we need to know a little bit more about smooth muscle. Smooth muscles are elongated cells. So they are like when we talk about the skeletal muscle, look at that, yeah? We have a sarcomere. Sarcomere is the basic structural unit for skeletal or striated muscle. So we have a sarcomere for the skeletal muscle, and it is like very proper, isn't it? If you remember that, you remember 2Z in the center, M, A band, I band. It's so unique, and it is so well structured. So that is the skeletal muscle, and their shape is like very elongated and longitudinal thick structures. That's what we know about skeletal muscle. But our smooth muscles are a little bit more elongated cells, like they are small cells. Look at that, it's just like a fish, little fish, like elongated cells. And just because they are elongated, they are also called smooth muscle cells or smooth muscle fibers. So don't get confused between smooth muscle cell and smooth muscle fiber. It is just because of their shape, elongated shape, like a fish shape. And they are called smooth muscle. They are also called smooth muscle fibers as well. So they are elongated muscle. Do you know the diameter? Not really. No, who cares? And they have centrally located nucleus. So their nucleus are in the center. And like our skeletal muscles, they will have sarcolemma and then endomysium. So I believe you all remember endomysium, perimysium, and epimysium. So these are the connective tissue sheets which covers the skeletal muscle cells, skeletal muscle fibers, and big skeletal muscle organ itself. The same thing, they are also covered with the endomysium. And the smooth muscle cells are called smooth muscle fibers. So it is the same, don't get confused. And they are arranged in sheets, so it is like layer by after layer. So it is, to some extent, it looks like a stratified squamous epithelium. So like it looks like, like and there is no sarcomere, so no ZZ or no M line or no like A band, I band, nothing like that. They do not have sarcomere and they do not have striations. So a few little things we need to know about. This is just a reminder about the skeletal muscle, which if I have to remember, then 2Z, in between 2Z is like in the center, M line, and you can see A band, and thin line is I band, and this thick is H band. And on top of that, we have got thin fiber, which are actin, and thick fiber, which are myosin. So that's what we know about skeletal muscle. Hey, although the smooth muscles do not have sarcomere, they still do have these myofilaments, which are actin and myosin. So yes, it is not as organized and structured like a skeletal muscle or striated muscle. They still have the thick filament, which is troponin, and thin filament, which is actin. Myosin and actin. They still have the actin and myosin. So to some extent, it looks very different, but the components are, yes, I mean, they are slightly similar, you know, because we need actin and myosin to contract on each other. So that's why we still need this. These actins and myosins are called myofilaments, and these myofilaments present in the smooth muscle. So the smooth muscles, they are elongated shape, and they do not have sarcomere, but they still do have myofilaments, and they have one single nucleus. It is in the center. And this is the relaxed smooth muscle, and this is the smooth muscle in a contraction phase. Look at that. It is an elongated muscle, and now it contracts, and that way make the muscles contract. Yeah. And if you look at that, the smooth muscles and their inner structure and their cytoskeleton. Cytoskeleton means C-Y-T-O-S-K-E-L-E-T-O-N, cytoskeleton. Cytoskeleton means, cyto means cell, skeleton means structure, bony structure. So cell structure, like cytoskeleton, for example, these intermediate filaments, like if you look at these line like a lace, like a little joint meshing around here and there around the smooth muscle. So that is one example of cytoskeleton, and that these cytoskeleton and the actin and myosins are very much well connected. And if we look at this intermediate filaments here, they are tension resisting fibers. So when they are in a relaxing state, they are in this condition, you cannot stretch them anymore because they will resist the tension, which is the pulling force. And if you follow the intermediate filaments, you can see a little dot here where the two filaments are crossing each other. Look at that. Look at the intermediate filaments crossing each other. That's the area. You can see a dense body. So this dense body will be acting like a Z disc of the sarcomere. So the dense body is let's say equivalent to Z disc. So what really happened is this dense body will be connected to the actin, which is the thin filament. That is something we saw, and we saw with the striated muscle, because Z disc here on either side, and it is connected to the actin. Thin filament actin is attached to the Z disc. So the same thing, like this Z disc equivalent, which is the dense body, will be acting as a Z, and then they will stay there, and this intermediate filament, look at that, they will just squash like an accordion, like together, and make the smooth muscle cell short. And if we look at the outer surface here, we can see small little caveolae. Caveolae, what is caveolae? These are like a sarcoplasmic reticulum entering into the smooth muscle cell. And there it is a place for the nerve endings to come and rest on that area, which we give the signal, which is the acetylcholine signal, and let the smooth muscle to contract. So this the caveolate, and you can also see the gap junction here. The gap junction, as we know, the smooth muscle cells are like layer after layer after layer. So the nerve ending might come only to one smooth muscle cell, but this activation, nervous activation from one smooth muscle cell will go to another smooth muscle cell via the gap junction. So that's why smooth muscle, if we stimulate one smooth muscle, many other smooth muscles will get stimulated. And this stimulation will go from one smooth muscle to another smooth muscle via the gap junctions. And just because we can stimulate only one smooth muscle, it takes a long time for the whole smooth muscle sheet to get contraction. So therefore, the smooth muscle contractions are slow and on and gradually come up. And when they relax, they gradually go down. That's why when we have belly ache, like abdominal pain, the gripping sensation slowly, gradually come up. And they're really, really feeling tight and gradually ease away. So that is because of the smooth muscle nervous stimulation. So cytoskeleton, what is a cytoskeleton? It is a structure inside the cell which is made of amino acid chain. Its function is to keep everything in order together. It's just like a framework of a house, framework of a human body, like the same thing, like framework of a cell, that is called cytoskeleton, which links, tether, and anchor all the components inside the cell. What are they? They will be adherents, intermediate filament, which we saw, and dense body, which we saw. What is adherence? Adherence is, it is something, it will adhere to the another smooth muscle cells or smooth muscle fiber. So cytoskeletons are made of amino acid chain. They are inside the cell. They give the form and structure and keep everything in order of the smooth muscle cell components. And they include adherents, intermediate filaments, and dense bodies. Yes, we have seen the intermediate filaments, which are running like a lace fibers here. Where the crossing are, we will say dense body. These dense bodies are Z-disc equivalent. So dense bodies, they will bind to the endomysium and inner and outer. They just try to attach everything and holding everything together. So contraction of the smooth muscle, the calcium will enter this via the reticulum, the caveolate. It takes about 30 times longer than skeletal muscle. So let's say if by hands, the muscles of the finger, bang, contract, relax, contract, relax. So it is so quick, but for the smooth muscle, it will take about 30 times longer to contract. And when it comes, it will not let go. It will be sustained, and it just keep doing on and on and on. It is fatigue resistant. So it is for the all day, whatever we eat, they will have to work hard. If we do not eat, they will stay moving the gastrointestinal tract. So it is a low energy requirement system because contraction is slow and relaxation is slow. So the energy requirement is slow and they do not have many mitochondria. So how do these smooth muscles get control? Of course, number one, nervous system. Nervous system control every part, So nervous system, which is the autonomic nervous system, not the somatic nervous system. Autonomic nervous system means it is doing everything in automation. Like it's just moving everything. The heart is beating. We don't need to ask the heart to beat. The respiration is keep going. The same thing like our gastrointestinal tract, the urinary tract, the reproductive system, they are always to keep doing their job without being asked to do so because of the autonomic nervous system. Yes, our conscious mind can control this autonomic nervous system to good extent, but even if we do not influence the autonomic nervous system, they will keep doing for us. So single unit innervation that's what I say. I will explain that in the next slide. And mechanical control, stretching. So let's say if we eat food, and once the food gets from the oral cavity into the esophagus, then esophagus muscles are smooth muscles. Once the food enters into the esophagus, the food stretches the esophagus. By stretching the esophagus, we are stimulating the esophagus with the mechanical means. So once the esophagus is being stretched, it will contract again. It is automaticity. So if it is being stretched, it will dilate. Because of the dilatation, it will be followed by contraction. That is the autonomic, and this sort of stretching is called mechanical control. Because we stretch the muscle, it will get stretched, and in response, it will contract again. So if we swallow food, and once the food gets into the esophagus muscle will get stretched, and that will be followed by a constriction, and that the food will be pushed forward. And hormonal control, of course, some of these smooth muscles are under really, really good hormonal control, like for example, oxytocin and uterus. So when there is delivery, like childbearing, because uterine muscle, which is smooth muscle, is being stretched already. Once there is contraction, then it will just squeeze the baby out. Because baby is stay inside, the muscles are being stretched again and contraction again. So that is the smooth muscle hormonal control. Because when there is a labor, the hormone oxytocin from the pituitary will go up, and then this oxytocin will make the smooth muscle contract, push the baby out. The baby is stay inside the womb, so it cannot get. If it will get pushed again, then it will just stretch again. So that is what we call the positive feedback mechanism. So the smooth muscles are controlled by nervous system, mechanical control, and hormonal control. Like as we say, the smooth muscles, they are like a fish shape or elongated shape, one single nucleus in the center, and they are arranged in multiple layers. We can see the multiple layers now, and we can see the nerve, which is coming from the autonomic nervous system. Autonomic nervous system, we can see the nerve coming from the autonomic system, and it ends like a little beads here, like the autonomic nervous system gradually ends as a beads, which are called varicosities. So these varicosities contain neurotransmitters, so which is the acetylcholine, and they will release these neurotransmitter, and they will start the signal so that the calcium can go into the smooth muscle and get the contraction of the myofilaments, and that will improve the intermediate filaments. So autonomic nervous system, hey, we have to study autonomic nervous system to good extent. It will be included in the nervous system lectures. And when we are here, we just try to sort out a little bit so that we have some basic idea about the autonomic nervous system. And this especially autonomic nervous system for the gastrointestinal tract, it is called enteric. Enteric means gastrointestine, enteric nervous system. Like we saw that these small little varicosities, and these little varicosities are filled with the neurotransmitter. And this is a reminder, we saw these two, myenteric nerve plexus and submucosal plexus. Submucosal, how many layers do we have in the gastrointestinal tract? We said 4, not 3. This is the exception. Mucosa, submucosa, marcel, and serosa. Mucosa, submucosa, marcel, and serosa. Mucosa has 3. Mucosa has 3 layers. What are they? The epithelium layer, the connective tissue, which the epithelium sit, which is called lamina propria, and there is a small layer of marcel, which is called submucosal layer. So this is the mucosal layer. Submucosal layer, there we have lots of lymphatic tissues, blood vessels, nerve, and the lymphatics. And the marcel layer, in marcel layer, usually 2 inner circular and outer longitudinal. And in between these 2 circular and longitudinal layer, we have a nerve plexus, which is called myenteric nerve plexus. Myenteric means gastrointestine, myenteric nervous system plexus. This nervous system plexus will supply on the circular and longitudinal smooth muscles of the gastrointestinal tract, and that will give the peristalsis movement of the gastrointestinal tract. So I believe you remember that picture, like a transverse section of the gastrointestinal tract. So myenteric nervous system and submucosal nervous system, they are under the control, the name of the autonomic nervous system of the gastrointestinal tract, which is also called enteric nervous system. So let's go and talk a little bit about autonomic nervous system. Yeah, so we need to know a little bit more about autonomic nervous system. And so this is the basic slide diagram of the nervous system, which we will elaborate more when we come to the nervous system lecture. The nervous system can be divided into central nervous system and the peripheral nervous system. So whenever we say nervous system, I want you to remember 2, central nervous system and peripheral nervous system. What is central nervous system? Central nervous system means our brain and the spinal cord. That's it. It's simple. So anything other than the central nerve, anything other than brain and spinal cord is called peripheral nervous system. So it is so easy. So the brain inside the cranium, and there's the spinal cord inside the spinal column. These only 2, they are central nervous system. For the rest, the peripheral nervous system. Of course, if you really think about that, this brain, how this brain is going to control this tip of the finger? No, it has to come out from either the brain or the spinal cord. And now we have to come out from this brain or spinal cord. We come and supply the tip of the finger or tip of the toe or the eye. So these nerves coming out from the brain and spinal cords, they are all called peripheral nervous system. Therefore, our peripheral nervous system, we will have to divide it into sensory and motor. Sensory and motor system. Sensory means if we touch with our finger, if we touch something, we feel it. This little sharp sensation or heat sensation or soft sensation, that's area of the skin, we have to stimulate and come along the muscle and go to the brain, and the signal come out as, hey, it is hot, hey, it is soft, hey, it is rough. So this sensation, every sensation coming into the brain and spinal cord is called the afferent division or sensory division. So afferent means anything coming from the periphery outside, coming into the brain and spinal cord. That is the afferent sensory division. Then if we, now our brain knows we are touching something and it is hot, and the brain knows that this is not a pleasant sensation, it is too hot, and we pull our finger back. That is our voluntary movement, or might be involuntary movement as well, like our gastrointestinal tract. So that is the motor system, movement system, and which is also called efferent. So anything coming out from the brain and spinal cord, from the brain and spinal cord to the target organ, it is called the motor movement division. So now sensory division and motor division, of course, it is, it is comes under the peripheral nervous system, because the brain and spinal cord cannot go out and touch it. So the sensory sensation can be coming from the somatic or visceral sensory. Somatic sensation means, somatic means body, body means our let's say our voluntary control, like our touch, temperature. So these are the voluntary control. These are under the somatic sensory. Like if we touch it, it is sharp, it is soft, it is hot. These are the somatic sensation. It will go along the sensory afferent to the periphery, along the sensory afferent to the periphery, and finally we go to the brain and spinal cord, central nervous system. And the same thing, like if the food bolus we swallow into our esophagus, the esophagus knows as well that esophagus being stretched. So the esophagus knows that it has been stretched. So it will respond with the contraction. The food come into the esophagus, stretch the esophagus, and the esophagus know it has been stretched. It will respond and with the contraction. So that sensation, the esophagus being stretched, is the visceral sensation, which we cannot feel, but the esophagus or our stomach or our duodenum or our urinary bladder, they can feel it. All these visceral organs in our body will go along with the afferent sensory division, along the peripheral nervous system. They will go to the central nervous system. So let's say if we eat lots of food, our stomach will just bloat it, distend it, and that distension tell us, come along the peripheral nervous system, come to the brain, and we know that, hey, our stomach is full. Then what we do, we just send the sensation with the motor system, efferent system, motor system, efferent system, along down, and then we go along the autonomic nervous system, and all. Just 1 minute, please. So motor system, autonomic nervous system, and via the sympathetic and parasympathetic. So sympathetic and parasympathetic, which is under the autonomic nervous system, they will play very opposite role. It is just like, like Republican and Democrat. So if something going to increase the rate, the other one is completely opposite, will decrease the rate. So for example, sympathetic division will increase the heart rate. Parasympathetic will decrease the heart rate. Sympathetic division will decrease the motility of the gastrointestinal tract. Parasympathetic will increase the motility of the gastrointestinal tract. So these sympathetic and parasympathetic is under the autonomic nervous system, and which is under the motor division, purely motor, nothing to do with the sensation. And this autonomic nervous system will increase the motility of the gastrointestinal tract or reduce the motility of the gastrointestinal tract. And this motor division, somatic motor system, is our voluntary control, and this is for the involuntary control organs, and this is for the voluntary control organs. So for example, like our bicep muscle or the muscles for the eye, orbicularis oris, orbicularis oculi, they will be under the somatic nervous system, and our gastrointestinal tract, urinary tract, our reproductive system, they will be under the autonomic nervous system. So the portion we were talking about, enteric nervous system, it comes under the autonomic division of the peripheral nervous system. Autonomic division of the peripheral nervous system. Right. So this diagram is the same, like central nervous system, peripheral nervous system. Here, what I'm going to emphasize is the vagus nerve and the splenic nerve. Splenic nerve is, these are the nerve fibers for the gastrointestinal tract. These will take sensation of the visceral organs in our abdomen, and they will take along the sensory efferent division along the peripheral nervous system, will go to the central nervous system, and central nervous system will respond and come back along the peripheral nervous system. We go into the motor division group, and we go to the autonomic nervous system division, and we will act accordingly via the sympathetic and parasympathetic division. And these, because they are supplying the visceral organs in our body, and therefore they are also called visceral motor system. So this is the, a very good diagram telling about what the sympathetic and parasympathetic nervous system do. And don't lose the track. Sympathetic and parasympathetic division is autonomic nervous system, which is the motor division of the peripheral nervous system. So this sympathetic and parasympathetic division, I want you to take 2-3 minutes to have a look at this diagram. It is completely opposite, this sympathetic and parasympathetic. So sympathetic dilates the pupil. Parasympathetic will constrict the pupil. Sympathetic salivary gland, negative effect. Parasympathetic salivary gland, positive effect. So sympathetic is more related to the fight and flight. So you are going to fight, you have lots of adrenaline, or you are going to run, you have a lot of adrenaline. So you don't think about eating, you don't think about taking a rest. So parasympathetic is more like rest and digest. So rest means, hey, your eyes gradually close, your gastrointestinal tract starting to move and move and move. So it will have more positive effect on the stomach, pancreas, gallbladder. So that sort of stimulation is parasympathetic, and sympathetic is fight and flight. Hey, you ran away, you got loss of energy, loss of catecholamines, and all the blood will flow to the skeletal muscle. The blood will not flow to the gastrointestinal tract. So that is the difference between sympathetic and parasympathetic division, and this is a little bit more related to the our gastrointestinal tract. And parasympathetic has positive pushing effect, parasympathetic pushing effect on the all the organs in the gastrointestinal tract. They will increase the stomach motility, they will increase the gastric acid secretion, They will ask the liver to digest more. They will ask the pancreas to secrete more. And they will ask the colon to move more. So that is the parasympathetic system. And so have a little look. We are not in the nervous system lectures yet, but it's just like a preliminary, so that when we start the nervous system, it is not too difficult for you, but don't take a long time. And so let's look at the esophagus. And we said, we talk about oral cavity, we talk about the mouth and the tongue already. So we will talk about esophagus. Esophagus is the tube which is connecting the oropharynx down into the stomach. So the main function of the esophagus is for transportation. Yeah. So what sort of epithelium do we want for the esophagus? Its job is for transportation. Hey, can anyone answer? Or you can type in the chat group.
What stratified squamous epithelium?
Yeah, stratified squamous, because squamous epithelium is in multiple layer, it is for wear and tear. Like look at our skin, yeah? Our skin is fighting for us against everything resistant, mechanical, chemical, bacteria. Our skin is fighting for us. It is like squamous epithelium in a multiple layer is for wear and tear. So this means esophagus lining, like whatever you swallow, it has to accept. Like you will swallow steak, you will swallow water, soft, hard. Sometimes you will swallow bone, it's really hard. So it needs to stand for the wear and tear. So we were going to use stratified squamous epithelium. At the lower end, when it gets close to the stomach, there might be some columnar epithelium. It is because the stomach epithelium is more or less columnar. But the whole part of the esophagus from the neck coming along the thorax, going through the diaphragm into just before it enters the stomach, it is mainly made of simple stratified squamous epithelium. The rules apply for esophagus. There will be 4 layers. They are mucosa, submucosa, marcel, and serosa. Of course, this esophagus is stuck to the posterior abdominal wall. Therefore, we will not say this is serosa. We will say this layer adventitia, like fibrous tissue. So mucosa, submucosa, marcel layer, and adventitia. The same like the all gastrointestinal tract. We have studied the basic of gastrointestinal tract already. So mucosa is made of stratified squamous epithelium. Submucosa, there will be areolar connective tissue. And marcel layer, we know that circular and longitudinal. And adventitia is fibrous tissue, because this fibrous tissue will stack the esophagus to the back of the posterior thoracic wall. And look at the lumen here. Like if we do not have food, all these layers are just like projecting into the lumen. And when we swallow the food, it will become, these projections will become flattened so that it gives the passage for the food to go in. So that's the esophagus. It's simple. So now you know the anatomy of the esophagus. The epithelial lining, how many layers, what is the job, transportation, and where is it coming from? From the oropharynx. Where is it going to? It goes into the stomach, and it is in the posterior thoracic wall, and it has to go through the diaphragm. It has to go through the diaphragm to get into the abdomen. In the abdomen, it is just about 2-3 centimeters, and it will come into the stomach. So, and which vertebral level this esophagus perforate the diaphragm? We said it is VOA 8, 10, 12. V mean vena cava, inferior vena cava. O for esophagus. A for aorta. VOA 8, 10, 12. Vena cava going through the diaphragm at the level of vertebra 8. O esophagus will go through the diaphragm at the level of thoracic 10 vertebra, and aortic abdomen aorta, thoracic aorta will go through the diaphragm at the level of 12 vertebral body level. So that is the basic. So you know a lot about esophagus already. Let's move on. It's too much to know. So we were just, then esophagus here, after passing through the diaphragm, it will get into the stomach. Of course, you know, it is the esophagus tube, and then it will change, become dilated, and that portion is called that portion is called the stomach. So at the junction of the esophagus and the stomach, there is a little place called cardia, C-A-R-D-I-A. And this little entry into the stomach is called cardiac orifice. So the spelling for the cardia is the same like our heart, cardiac muscle. So the cardia, C-A-R-D-I-A, the orifice, C-A-R-D-I-A-C, cardiac orifice. So the spelling is the same. So why am I talking too much about this cardia and cardiac orifice? Of course, it is as a sphincter, so that when we swallow food, the food from the esophagus can go into the stomach, but when we lie down, the food in the stomach cannot go back into the esophagus. It is really amazing, you know, it is really amazing. So when we do an operation around the cardiac orifice, it is not much we can see. It is just like a little bit thickened masses around that area. But the action it works, it's really squeezed it tight so that the food we eat in our stomach cannot go back into the esophagus. Otherwise, it will be a disaster, isn't it? That we cannot lie down after eating. Yes, of course, if this cardiac orifice is not competent enough, then our gastric acid can come back into the esophagus as well. So that is the cardiac orifice here, and then it will become, the tube become dilated, which is called the stomach. Hey, let's look at the different portions of the stomach. So you can see the cardiac portion. You can see the cardiac portion here, where the esophagus enters into the stomach, and you now know that there is a little orifice called cardiac orifice. And the big dome portion of the stomach is called the fundus of the stomach. Fundus of the stomach. And you remember this little calf is called lesser curvature, and you can see this big calf portion is called greater curvature. And this, the fundus portion of the stomach, this is the body of the stomach. And finally, this stomach will gradually narrow down to become the duodenum. So look at that here. Before it became duodenum, the portion of the stomach is called pylorus. Pylorus. Pylorus is a Greek letter. This pylorus, look at that. They divide the pylorus into 3 portions. Pyloric antrum, you know, pyloric canal, and there is also another valve which is called pyloric sphincter at the pylorus. So yes, anyway, whatever it is, this portion in general we will call pylorus. So the portion of the stomachs are, number one, the cardiac orifice or cardia, the fundus portion, body portion, pylorus portion, and don't forget the lesser curvature, and don't forget the bigger curvature, which is called greater curvature. So that is the anatomy of the stomach. And if we look at the muscles here, we always say, hey, it is gastrointestinal tract. There is inner circular and outer longitudinal. There is one more layer because this stomach has to put up with everything we do on our body. So it has one more extra muscle layer, which is the oblique layer, which is the innermost layer of the stomach. So we know that outer longitudinal layer, inner circular layer, outer longitudinal layer, inner circular layer, and there is one more extra layer for this, especially for the stomach, which is the oblique layer inside. Of course, because of the muscle direction going into the here and there and then there, so it will just really grip the food we eat, really just mix up with all the acids inside the stomach, or the pepsin inside the stomach, so that the food, before it goes into the duodenum, the food is well marinated and digested to a good extent already. So that is the job of the stomach. And even the muscle, it has got one layer on top. So whatever, because it has to put up the burden of whatever we eat that will come into the stomach. It has to solve the problem. So that is the layers of the stomach. And if you look at that, some people say, hey, the stomach is in J shape. How can you say J? No, it is coming along here and going up like that, J. Okay, fine, you know, like stomach is J shape, fine, yes, I accept that. So this is the little cardiac portion, fundus portion, body portion, and the greater curvature, lesser curvature. This is the pyloric portion. And you can see now the stomach is very closely related to the spleen. So spleen here. And some people say, you know, the stomach, of course, we know that stomach is in the epigastrial region, but some say if we eat loads and loads of food, this J shape can go down and down and down, and it can even get to the pelvis. Hey, forget about that. Inside our stomach, we get two important chemicals. Number one is hydrochloric acid, and number two is pepsin. Pepsin derived from pepsinogen. So I believe everyone drink Coca-Cola, Coke, Pepsi, Coke and Pepsi. So yes, this is similar to Pepsi, but it is pepsin, pepsinogen. And it's the pepsinogen will become pepsin when it is treated by the hydrochloric acid. So stomach hydrochloric acid, it is secreted in hydrochloric acid is secreted in the stomach. This hydrochloric acid will kill some bacteria. This hydrochloric acid will activate pepsinogen into pepsin. This pepsin is going to start digesting the protein we eat. So this hydrochloric is the big daddy inside the stomach. Yeah, we need a lot of hydrochloric acid, but if it is too much hydrochloric acid, then we will get acid burns. So it is, we have to really fine tune. But whatever it is, this hydrochloric acid will kill the bacteria inside the stomach, will stimulate the pepsinogen to become pepsin, and this pepsin is going to treat on the protein we eat, and that protein is start digested. And inside the stomach, we will absorb water, we will absorb electrolyte and some drugs. For example, like aspirin we take will be absorbed in the stomach as well. So the stomach is a very important structure. So look at the surface, inner surface of the stomach. So this is the inner surface of the stomach. If we look carefully, there are small little bit holes, like a rabbit holes. There are small little rabbit holes on the surface of the stomach. And if you track down into the little this pothole, you can see this little glands inside here. So let's study about these little pit holes. You know, if you look at that from outside, you can see small little pit holes here on the surface of the stomach, which is in the mucosa layer, submucosa layer, which is here, and we have the marsa layer here, and this is the outer serosa layer. So we are going to concentrate just in the mucosa, the little rapid holes, it's here. That's what we are going to concentrate on. And these little holes are called gastric pits. You know, little pit holes here, little pit hole, and then you just follow and track into the hole, and let's see. These little track are lined by a cell which is called mucus cells. You know, it is closer to the gastric surface. It is called mucus cells. So this mucus cell will secrete mucus, and which covers the outer coating of the stomach, so that it prevents acid inflammation. And if you keep following, going down into the tract, and you can start seeing the mucus neck cell. They will secrete mucus as well. And keep going there, and we are going to see the parietal cells, chief cells, and the whole structure is called the gastric gland. So in the gastric gland, we will have mucus neck cell, parietal cell, and chief cell. Oh my God, I'm not sure who studied all these. So now we have to study. So now we are going to study just the mucosa surface. Mucosa surface, they will have a small little pits. If you follow that, this mucosa surface, you will have the gastric pit, which will lead into the gastric glands. Look at that. So this is the micrograph, which is showing all the structures we are showing. But let's go back to the little bit more detail. And this is the cells we were talking about. Parietal cells. Parietal cells will secrete hydrochloric acid and intrinsic factor. So I believe you will have to study this. You will have to study this in the physiology, if you're doing the physiology class as well. So it is worth remembering, because when it comes to physiology, you will have to study the same thing. So parietal cell will secrete hydrochloric acid and intrinsic factor. And as we know, hydrochloric acid will change pepsinogen into pepsin. Pepsin is for the protein digestion. What is intrinsic factor for? Intrinsic factor is for B12 absorption. So parietal cells are important for secreting hydrochloric acid and intrinsic factor. Chief cell secrete pepsinogen. Chief cell will secrete pepsinogen, and the hydrochloric acid from parietal cell will act on the pepsinogen to become pepsin. And enteroendocrine cells here. So enteroendocrine cells will secrete gastrin. Gastrin will stimulate the parietal cell to secrete hydrochloric acid. So it's too much now. It's too much now. I'm not sure how to cope, but we know that the parietal cell will secrete hydrochloric acid and pepsino and intrinsic factor, and chief cell will secrete pepsinogen. Yeah, so that is what we should understand about the cells in the gastric glands. So gastric gland, we have multiple cells. And these are the cells, important cells in our stomach. Look at the duodenum now. Duodenum, look at that. Hey, let me keep you about another 3-4 minutes. Yeah, another 3-4 minutes, and I will give you a break. So look, after the stomach, it will become duodenum, jejunum, and ileum, which in combination called small intestine. Yeah, look at the duodenum. So duodenum has only 2 muscle layers, inner circular and outer longitudinal. There is no oblique layer like stomach. So if you look at the duodenum, it is also fold like a accordion here, longitudinal fold, transverse fold here. And even in the folds, there will be little villi here. And you can stay, if you look at the villi are made of microvilli as well. It's just to increase the surface area as much as they can in a small little tight space. So duodenum start from the pyloric orifice. Duodenum is a C-shaped loop, and then we become the jejunum. Look at that. It is the folding, the way it is folding inside internal surface. Look at that. Even for the folding, there will be further folding. It's just to increase the surface area. And look at the cells inside they will have absorptive enterocytes. So these cells, enterocytes, so intestinal cells, they will do absorption. Goblet cell will secrete the mucosa-associated lymphoid tissue that's in the submucosal region. So these are the cells inside the small intestine. Now you can see the microvilli here. So that is the microvilli. So we are looking at the microvilli. Yeah, so what's the time now? Okay, I will keep you like another 1 minute. So goblet cells, these are the microvilli. These are the microvilli, and these microvilli has got these absorptive cells and goblet cells. So they will secrete mucus. They will absorb everything and all the nutrients from the intestinal contents. And look at the duodenum here. So stomach will be here, and then stomach will be continue as the duodenum, which is a C shape. Inside the C shape of the duodenum, we have our head of the pancreas here. And the pancreas has got head portion, body portion, and tail portion. The tail portion of the pancreas will be going into the spleen, which is somewhere around here. So we need to know a little bit about this duodenum, pancreas, and liver. So at the moment, I will give you like 15 minutes break. Pancreas. So our pancreas is in the C-shaped loop of the duodenum, and pancreas has a head portion, which is this one, and body portion, which is here, this is one, and the tail portion of the pancreas. So the tail portion of the pancreas just twist and turn and extend into the spleen as well. And as we know, both the pancreas and the duodenum, they are stacked to the posterior abdominal wall. They are retroperitoneal structures. Look at the pancreas here, the gold yellow color. So pancreas has got a duct here. That is what we call main pancreatic duct, which is coming and draining all along the pancreas from the tail, along the body, through the head, and opens into the duodenum. And that is what we call pancreatic duct opening into the duodenum. This is called ampulla of Vater, V-A-T-E, Vater. That is where the space is. But before it opens into the duodenum, it combines with the cystic duct. Cystic duct is the duct coming from the gallbladder. So the bile which is made in the liver will be secreted out of the liver from the right hepatic duct and left hepatic duct, and then finally that bile will be stored in the gallbladder. Gallbladder will store the bile and will concentrate the bile. And when we eat fatty food, an enzyme from the duodenum, jejunum will stimulate secrete enzyme, which will stimulate the gallbladder to secrete the bile acid, and the bile acid from the gallbladder will come out as a cystic duct, and then finally become cystic duct and hepatic duct will combine together to form the common bile duct, CBD. That is what we call CBD, common bile duct. And that common bile duct will join the pancreatic duct and finally opens into the duodenum, which is usually second part of the duodenum. So this anatomy is really important, especially when we get to the pancreatitis, the inflammation of the pancreas, because the stone in our gallbladder will get dislodged along the gallbladder, along the cystic duct, into the common CBD, common biliary tract. And if that stone block here, just around the ampulla of Breda, it will block the pancreatic secretion, and there will be backflow of the pancreatic secretion, and then the pancreas can get inflamed, which is what we call pancreatitis. And if there is any blockage of the stone in the common bile duct here, the bile from the liver or the gallbladder cannot drain into the duodenum. There will be backward pressure in the liver, and that will give us the obstructive jaundice, yellow discoloration of the skin. So this is the hepatobiliary anatomy. And let's talk about the large intestine. Getting there now. So large intestine involves cecum and the appendix, ascending colon, transverse colon, descending colon, and sigmoid colon. So cecum, appendix, ascending, transverse, descending, and sigmoid colon, they are all under the heading of large intestine. Large intestine has got peculiar characteristics. These are, they have Taenia coli, they have hostrations, and they have epiploid appendages. Oh, what are they? Let's look at that. So let's start with the Taenia coli. Look at the Taenia coli. So Taenia coli, it is running all along the colon. Look at that. Don't look away. Look at that. This Taenia coli is running from the cecum, transverse colon, ascending colon, transverse colon, descending colon, and sigmoid colon. So what is this Taenia coli? Taenia coli means this is the thickening of the longitudinal muscles of the colon. So as you know, there are two layers of muscle, inner circular and outer longitudinal. This outer longitudinal layer thickening, it is called Taenia coli. And what is appendages, epiploid appendages? Hey, it is nothing more than little fat globules. What is the significance? I don't know. So this is the appendices, epiploid. Look at that. It is yellow, white, fatty, little stack on the wall, on the outside wall of the colon. And don't forget this Taenia coli, which is the thickening of the longitudinal fiber of the muscle layer. Just because this muscle is running like that, it's just like a tether the colon to make it shorter and shorter, and then we now have the hostration, which is called rostrum. So yes, so three features: tinea coli, which is the thickened muscle, longitudinal muscle. Because of the tinea coli, we have the tethering, which is what we see as a hostrations or called hostra, and the little fat globules which is attached. We don't know the significance of that. That is appendages epiploid. So these are the three characteristics of the large colon. And finally, look at that, this descending colon, sigmoid colon, will become straight, pretty straight, rectus, rectum, and finally become anal canal. Hey, so now we are getting close to our target, which is the anal canal. Yeah. So once we got to the anal canal, we got to the target. Hey, so the large colon, I want you to appreciate that the ascending colon, descending colon, they are stacked to the posterior abdominal wall. They are behind the peritoneum, retroperitoneal structure. Transverse colon and sigmoid colon, they are hanging down in the abdomen with the mesentery. So transverse mesocolon and sigmoid mesocolon. So yes, this diagram, as we say, you know, the ileum came into the cecum. There is a little thickening which is called valve, ileocecal valve, which is the one-way valve. So once the food from the ileum enter the cecum, it cannot go back to the ileum. It is one way. So therefore, you know, if there is any obstruction in the ascending colon or transverse colon here, the cecum can easily get distended because it is one-way valve. It cannot go forward anymore. It has got backward pressure and it cannot come back into the ileum because of the patent ileocecal valve, and therefore cecum can get perforated. So just a little bit careful with the cecum perforation, like because of the obstruction in the ascending or transverse colon. So this is the rectum and anal canal. Rectum and anal canal. Look at this anatomy. So this is upper portion is rectum. And where is the levator ani muscle here? Levator ani muscle. So I want you to introduce levator ani, levator ani, ani anus, levator means elevated, levator ani. Look at the levator ani. So the rectum, when it's passed below the level of the levator ani is called rectum, anus, and above the levator ani muscle is called rectum. Rectum has got little curvatures, which is called rectal valves. So because of the rectal valves here, the feces in the rectum cannot come out with the, you know, like flatus. So this is the rectum. Levator ani muscle level above the levator ani is called rectum, and below the levator ani is called anal canal. Look at that, anal canal is very short. It is a anal canal is very short. So if we poke our finger into someone's anus, we can easily reach to the lower part of the rectum. Let's look at the rectum here carefully. Rectum is very interesting thing. So this is the levator ani. So from this level, from the levator ani level, below it is the anus. Look at the anus. You can see little mucosa fold. Mucosa fold here. That is what we call anal columns. Look at that. It's just like a column here. One column, another column, another column. What is inside these anal columns? These are the inside. They will have little arterial endings and venous beginning of the rectum. So there will be small blood vessels inside the anal columns, and the anal column come down here and they fuse with the another inner column. Come down here, they fuse with the another column, and they are continuous with the each other, these inner columns. These continuity portion of the inner column is called inner valve. Look at that inner valve. Inner valve has got glands which secretes little mucus so that the feces can pass through the anus with some degree of ease. So inner valve has got inner glands, and inner column has got the blood vessels, which, like, if the blood vessels are dilated, it is the hemorrhoids, which is what we call piles. Yeah. And if we just keep looking at that, there is a little line here. There is a little line here, which is at the base of the inner valves. That is what we call pectinate line. Hey, look at that pectinate line. Pectinate line is here. So this is the pectinate line. Now, what is the significance of this pectinate line? Hey, now the important facts. The pectinate line, below the pectinate line, outside, this is the sensation of our normal skin. Above the pectinate line, so above the pectinate line, above, inside, it is the sensation of the autonomic nervous system. So now the sensation is very different. So if you take a little pin, yeah, like pin, and then if you poke the pin with somebody's anus, if it is outside, below the pectinate line, they will feel the sharp sensation. But if you poke with that little pin, and if you are poking above the pectinate line, inside the pectinate line, they might not feel it. They might not feel it because it is more like autonomic nervous system. It has become the visceral sensation. So below the pectinate line, outside the pectinate line is somatic sensation, and above the pectinate line, inside the pectinate line is visceral sensation. So visceral sensation, how can they feel it? You have to stretch it to feel it. But the pain, temperature, touch, sensation, pinprick sensation, it need to be somatic sensation, which is below the pectinate line. So that is like really interesting thing about the anus or anal canal. So rectum is a retroperitoneal structure, especially become lower third. So if we divide the rectum into upper third, middle third, lower third, so the sigmoid colon will continue as a rectum, which is more or less straight. So upper portion of the rectum, might be stay with some mesentery, or might be slightly behind the retroperitoneal, but starting from the middle to lower third, it really became retroperitoneal, and rectum has the rectal valve, which we saw that. And anal canal is only 3 centimeters long. So somebody's anus is only 3 centimeters long. And upper half of the anal column, we have anal valve, pectinate line. It is for visceral sensory. Inferior to the pectinate line is, we say, somatic sensation. And if we look at the anus sphincter here, look at the longitudinal and circular muscle fiber, which makes the internal anus sphincter. So that whatever we're talking about, the circular muscle and longitudinal muscles of the gastrointestinal tract, they form and they will become the internal anus sphincter, which is the involuntary control. And outside the internal anus sphincter, we have skeletal muscle fiber, which makes the external anus sphincters. Look at that, one external anus sphincter, external anus sphincters. So these are the external anus sphincters, which is our voluntary control. So if the time is not appropriate, we can squeeze it, this external anus sphincter, so that we don't poo. And internal anus sphincter is just the continuation of the muscle fibers of the gastrointestinal tract. So now I believe you can appreciate internal anus sphincters and external anus sphincter. External anus sphincter are skeletal muscles, which is voluntary control. Internal anus sphincters are smooth muscle, which is involuntary control. When the time is not appropriate, you want the external anus sphincter to squeeze tight. Okay, now, so how do we control this rectum and anal canal? Look at that. This is the voluntary control, from the nervous system, central nervous system, spinal cord. We come and stop and act on the external anus sphincter. Squeeze it tight, guys. Squeeze it tight because it is not an appropriate time. You cannot pull. And the internal anus sphincter, look at the internal anus sphincter supply here. Then once the fecal matter came from the sigmoid colon, get into the rectum will get stretched. Because it is being stretched, it is under the autonomic nervous system. So the stretching sensation will go to the brain and spinal cord and come back down with the motor, like sympathetic and parasympathetic will act, and this rectum wants to constrict, and we have to control with our external anus sphincter. A little bit about liver. So this is the anterior surface of the liver. The right lobe, which is really big. The left lobe, which is much smaller. Right lobe and left lobe. Liver has two lobes. So right lobe and left lobe. Right lobe is much bigger. Left lobe is smaller. These two lobes are divided by the falciform ligament. Hey, you remember falciform ligament? That is the mesentery going from the organ to the anterior abdominal wall. That is the falciform ligament. So falciform ligament divides the liver into right lobe and left lobe. Right lobe is much bigger, left lobe is much smaller. And lower part of the falciform ligament, it is called the ligament anterior, round ligament of the liver. So this is the anterior portion. This is the right side, this is the left side. So now I'm going to flip the liver and I want to look at the posterior surface of the liver. Bang. This is the posterior surface of the liver. This is the left lobe now. This is the right lobe. And there is the impression for the inferior vena cava. Now we are going to see two lobes which are include. Look at that caudate lobe of the liver, which is in the right lobe. And there is another lobe, which is the quadrate. So caudate lobe is at the top, quadrate lobe is at the bottom. We can only see them in the posterior aspect of the liver. And now you can see the gallbladder, which is stacked to the posterior and inferior portion of the liver. So yes, I want you to remember liver has two lobes, right lobe and left lobe. And if you look from the back, you can see the caudate lobe and you can see the quadrate lobe. Hey, what is the big deal about that? Yeah, not much, but just to remember caudate and quadrate lobe. So look at that, caudate and quadrate is in the right lobe of the liver and left lobe of the liver is pretty small. They are divided by the round ligament of the liver and we can see the big inferior vena cava, which is stacked on the posterior wall of the liver, and we can see a small little gallbladder, which is stacked on the inferior and posterior portion of the liver. So I am going to make a slide, make a cut in the liver, and I am going to look this slide, prepare it, look under the microscope. And that is what I am going to see. So now, if we make a cut the liver and look under the microscope, and you can see this hexagonal shape, multiple hexagonal shape. This is what we call lobules of the liver. Just sit tight. The lecture is near going to finish. So if we cut the liver, put it on the slide, prepare the slide, and we are going to look at with the microscope, if we look with the microscope, we will see multiple hexagonal shaped cells. These are what we call lobules of the liver. And if you look at each and every lobule of the liver, there is a central area, which is what we call central veins. Hey, look at that. Central veins here. And this hexagonal shape, they are made of connective tissue. It's not surprising, isn't it? It's connective tissue that will split the liver into multiple small little lobules. And in the center, we have the central vein. So keep looking at that, keep looking at that. So look at the slice of liver, put on the slide, look at the microtubule, you will see my hexagonal cell. Hexagonal cell has got central veins. And keep looking now, I'm going to show you, hey, oh my God, this is the central vein, this is the hexagonal shaped cell. And at the each and every corner of the hexagon, look at that. So each and every corner of the hexagon, 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6. Each and every corner of the hexagon, we have the artery, we have the vein, and we have the bile duct. So 3 structures. 3 structures present in each and every corner of the hexagon. 3 structures, so we will call it portal triad. Portal triad. So all these liver cells inside the hexagon, little liver cells here, little liver cells will generate biles, and the veins will be communicating with these veins and the central vein, and all these little liver cells will communicate with the bile duct, so that the bile secreted made by the liver cells will come into the bile duct and we can come out into the bile. And pancreas, as we know, pancreas has got exocrine and endocrine function. Endocrine means no ductless gland, which secrete hormone and directly into the blood vessel. So what is that? Insulin is the endocrine function of the pancreas, and exocrine pancreas, they will secrete bicarb. Bicarb will come along with the main pancreatic duct and come into the duodenum through the little hole called ampulla of Vater. So main pancreatic duct, there will be some accessory pancreatic duct. And look at that pancreatic acinar cell, which is not beta cell, which secrete insulin, alpha cell, glucagon. It is different. Like pancreas has got this sort of cell, exocrine cells. These, look at the cells here. They got a lot of cells and they secrete about 20 enzymes, you know, this for the digestion and absorption of the food we eat. So these acinar cells have multiple cells, and then they will secrete all their secretion into the pancreatic duct. Small duct will become the cells, and then finally become main pancreatic duct, which is draining all along the pancreas. Look at the pancreas here. This is the duodenum, which is the C loop. And inside the C loop, we have the head of the pancreas and body of the pancreas and tail of the pancreas is running along and going into the spleen hilum. So look at the relationship between the liver, gallbladder, which is somewhere around here, pancreas and duodenum and the spleen. So they are all very tightly packed inside our upper portion of the abdomen. Hey, I have created a homework in our gastrointestinal tract homework. This is the cadaveric specimen looking at the anterior abdominal wall muscle. So we are looking from the left side, anterior. So this is the center, this is the genitals, this is the left hip, and this is the right thigh. And these longitudinal muscles running from the thorax down to the pubic symphysis, they are the, what do we call that? They are the rectus muscle, rectus straight, and these are outermost is external oblique. Second layer is internal oblique, it's running outwards and laterally. External oblique is downwards and medially, and which is completely going horizontal is transversus abdominis muscle. So this is included in our what do you call that, the homework portion of the gastrointestinal tract. And now it comes to the end of our gastrointestinal tract lecture. It is quite a lot, but I hope we have given enough time to study this gastrointestinal tract. It is a 3 lecture, and I know it is a little bit overwhelming. You might have forgot, like when we start the middle portion, you will forget the last portion of the so everything, like I know everything is not easy. Therefore, we take 3 weeks. I just want you to go through so that you know what I have talked about, and I will open the homework.